for a PTSD diagnosis, and this could be direct exposure, witnessing a trauma, indirect exposure to trauma, so adverse details usually in the course of a professional setting, such as work or school. Learning about a relative or family member was exposed to trauma or a threat of death or died, and it has to be violent or accidental. So what this looks like in the office is you ask a parent if the child has been exposed to any known stressors, death of a loved one, friend, a car accident, maybe abuse that the child may have been a part of. For example, I had a case where a 13-year-old witnessed a friend getting hit by a car. Another example was a 10-year-old watching an older brother almost drown in the pool. The key takeaway is there's exposure. Ask open-ended questions. So criteria B is intrusive symptoms, and at least one is required, and it has to be associated with a traumatic event. So re-exposure to the traumatic event in the following ways: distressing memories that are recurrent, involuntary, and intrusive to the traumatic event. In children older than 6, repetitive play may occur in which themes or aspects of the traumatic event are expressed. For example, I had a 7-year-old female who would draw different images depicting a monster that would come into her room at night and hug her. In children younger than 6, these memories may not appear distressing, and they may be expressed as play reenactment. And an example would be a 4-year-old who licked her doll in an inappropriate way. Nightmares and night terrors, these are just dreams related to trauma in children. These may be scary dreams without recognizable content, so for example, shapes and colors. There may be also a fear of being alone. Flashbacks, when an individual feels or acts as if the traumatic event is reoccurring. Children, again, may reenact this in play. Emotional distress after exposure to a traumatic event. These can be external or internal cues. Physical reactivity after exposure to a traumatic reminder, and this can also be internal or external. In clinic, a parent may report that a client is acting inappropriate with her dolls and experiencing nightmares during a well-child visit. The child was referred to therapy, and it was found that she was actually being sexually abused by a family member. Another thing to look at is a regression in age. During a stressful situation, a child may revert back to a previous coping skill. The parent may see different types of coping skills that don't match the child's age, whether it's their mental or physical age. So for example, I had a 15-year-old who regressed to bedwetting and sucking their thumb when upset, and that was not the child's normal coping response. Next slide. So avoidance, and you will need at least one. Avoidance would be some type of, they avoid traumatic related stimuli after a trauma has taken place. They avoid trauma related thoughts, feelings, or memories that are closely associated with the traumatic event. They avoid trauma-related external reminders, so this could be people, places, conversations, activities, objects, or situations. The parent may report that the child is acting oddly. The parent may note that the child does not want to ride in a car or acts up when they're around people, places, such as hospitals or objects. The key takeaway is that the child is avoiding something and is experiencing high distress. Next slide. So criteria D is negative alterations in cognition and mood, and you need 2 of the following symptoms. So this is negative or unhealthy thoughts or feelings either beginning or worsening after the trauma event or events have occurred. There is an inability to recall key features of the trauma, typically due to dissociation and not other factors such as head injury, alcohol, or drugs. Overly dramatic, negative thoughts and assumptions about oneself or the world. For example, I am bad, I will never trust anyone. Those I statements. Over the top, constant, and distorted cognitions about the cause or consequences of the traumatic event to the point of blaming oneself or others for causing the traumatic experience. So for example, it was my fault that I was assaulted. Negative affect and persistent negative emotional states, so guilt, horror, a sense of horror, fear, anger, or shame. Decreased interest or participation in significant activities. For example, no longer interested in sports that the child participated in before the trauma. And then there's also feeling isolation or detached from others, such as family or friends, and difficulty experiencing positive affect or feeling. So loving oneself, feeling happy, or just satisfied with life. Next slide. Criteria E is noticeable changes in arousal and reactivity associated with the traumatic event. These changes in behavior will begin to worsen after the traumatic event has occurred. Must be exhibiting 2 of the following. Irritability and aggression. This is with little or no provocation, and this can be expressed in verbal or physical outbursts toward people or objects. Risky or destructive behavior. This is not behavior that is usual for the client. For example, jumping off playground equipment, fighting with others, or destroying toys. There's also hypervigilance, heightened startle reaction, difficulty concentrating, difficulty sleeping, staying asleep, falling asleep, or restless sleep. And parents may report an unrealistic response over something small. Next slide. So criteria F is just duration of symptoms. So this is kind of breaks down into symptoms from criteria B, the intrusive symptoms, criteria C, which is the avoidance, criteria D, which is negative alterations in cognition and mood, and criteria E, which is the noticeable changes in arousal and reactivity associated with the traumatic event, and they must be present for 1 month. So let's put this in a clinical example. The example is a mother dies in front of a child at age 12. Criteria A, stressor. The child is experiencing nightmares or flashbacks about the mother's death and the aftermath. Criteria B, avoids trauma-related external response or reminders. So people around her at the time of her mother's death and the home that her mother passed away in. That would be criteria C. She also had an inability to recall certain certain features about her mother's death. She said that a monster hurt her mother. The child also reported feeling alone and decreased interest in her favorite activity, which was dance. The client also experienced hypervigilance and would startle easily, and she had difficulty sleeping, which is criteria E, and all of this lasted for more than 1 month. Next slide. So criteria G is just symptoms have created distress or some type of impairment in the client's life, and this can be social engagements, work, home life, and school. And then criteria H are just the exclusions. These are symptoms that the client is experiencing that are not due to medication, substance use, or other illnesses. Now let's put this into a clinical setting, and this is Dr. Simmons.
Yes, ma'am. So I am not, everyone can read, so I'm not going to read this whole example, but let's imagine that you have, we're going to call her Emma, who is a relatively healthy 15-year-old girl who, presents with abdominal pain and nausea that's been going on for about 3 months. She occasionally vomits with this nausea and has lost about 10 pounds in 2 months. She really has no medical history. She has not been out of the country, hasn't been traveling, hasn't been exposed to anyone who's been ill. No routine medications, no allergies. She's missed a couple of days of school because of the abdominal pain, but reports that her grades are good overall. So imagine that you examine her, everything is completely normal. A previous workup that includes, urine analysis, blood cell count, metabolic profile, ultrasound, CT scan, everything is negative. So parents are presenting to you wanting to know what the problem is and requesting a referral to a gastroenterologist. I can't speak today, but they're wanting specialty care to figure out what is going on with their daughter. So if we looked at this on the surface, we could say, yes, this feels like a physical problem. We'll get her referred, get the specialty referral going. However, when we take a little bit more time and actually pull Emma to the side and talk with her alone, she discloses that someone broke into their family home about 3 months ago She describes that her parents tell her that, it's no big deal, nothing got taken, no one was hurt. But she's having nightmares, avoiding the room that was broken into, and generally feeling unsafe in her home. So we really, this is just a common example of why we want to be considering what factors may be happening in the child's environment that may be precipitating different symptoms. So in the clinic, trauma can present in a lot of different ways. So it may look like psychosomatic symptoms, so stomach aches, headaches, joint pain, chronic pain, anything along those lines. It may be an increase in angry outbursts or emotional outbursts, especially triggered by seemingly small events. If a child is suddenly overly clingy or has an increase in separation pain. We also want to be looking at an increase in lack of focus and restlessness. While these things may present as a attention deficit disorder, we want to be really looking again at the environmental things that may be precipitating that. Like Elizabeth mentioned, we want to be paying attention to change in normal interests. So if a child is no longer interested in sports or their normal extracurricular activities, spending time with friends, seeing particular family members, those are all things we really want to be paying attention to. And then finally, we really want to be looking at avoidance or wanting to escape certain things. These are all clues that really should give us all pause to kind of say, hang on, let's look at what's going on in the environment. We also know that trauma inhibits the development of specific areas of the brain that are responsible for executive functions such as working memory, inhibitory control, and cognitive flexibility. These skills are required to learn new material, function in social settings, and stay focused. They allow children to display self-control, stay on task despite distractions, and hold one idea in their mind as they learn the next step in the process. Executive function skills develop through practice and are strengthened by experience. But for children who have experienced a traumatic event, the skills may not develop appropriately, resulting in missed milestones. So when developmental delays are identified, exposure to trauma should be something that's considered. This will help you as the provider make the most appropriate referral for evaluations or services moving forward. Trauma also influences the brain in a way that can result in behaviors that often are misleading. So some common misunderstood causes may present as depression, ADHD, developmental delays, behavioral disorders such as ODD or conduct disorder, bipolar disorders and severe mood swings, as well as anger management difficulties. So when we are thinking about differential diagnoses or different kind of differential explanations, we do want to be considering several other things. So there may be co-occurring depression that is either happening within the context of the traumatic event or may be a separate standalone disorder. There's also commonly anxiety disorders, again, that are either co-occurring or are happening under the umbrella of traumatic stress. ADHD is very typically confused with trauma because, like we've talked about, trauma can affect the development of executive functioning, focus, fidgeting and restlessness, as well as that ability to sustain focus and sustain attention in both a school and a home setting. I also briefly wanted to mention psychotic disorders because it is not uncommon for children to experience both visual and auditory hallucinations related to the traumatic experience. And when we are seeing that, we really want to be, again, connecting those hallucinations and those psychotic experiences to what the child may have experienced. It's very rare to see things like early onset schizophrenia. So we want to be sure, again, that we are correctly identifying the precipitating factor. And then finally, I also wanted to mention personality disorders. So given the amount of emotional dysregulation that trauma can occur or can cause, it is not uncommon for patients to present with borderline behaviors. However, I think it's important for us to recall that personality disorders are not something that is diagnosed until the patient and client is at least 18 years old. And this is really something that we are looking at over time. So again, while a patient may be presenting with emotional dysregulation or borderline features, we're not going to diagnose a full personality disorder until much later in that patient's life. So we know that up to 2/3 of children will experience some traumatic event in their lives, but about 16% of those children who experience a traumatic event will actually go on to develop full-blown PTSD. However, PTSD is a condition that's likely to persist without identification, which means that early identification is a key component of preventing and mitigating the disorder. However, we know that assessing the full DSM-5 diagnostic criteria can be time-consuming, especially in primary care settings, even though that's typically the setting where children are presenting following a traumatic event. Consequently, providers need screening measures and ways to screen that accurately and quickly sort between trauma-exposed youth who likely need additional interventions and those who may not. So what we have worked on for the purposes of this presentation is actually developing a simple roadmap to help primary care providers recognize trauma in the primary care setting and appropriately respond to different trauma presentations. As a heads up, we have all of these available in handout form, including a copy of the PowerPoint and all of the resources that we are going to be mentioning from here until the end of the presentation. So if you are interested in getting a copy of that, I believe Laura put the CPAN email in the chat. Please send us an email and we would be more than happy to provide you with a copy of the resource packet that we put together. So the first step in this roadmap is just screening for potentially traumatic events. A standard recommendation is universal screening for potentially traumatic events. Some families may present in clinics specifically to discuss a trauma, but many more fail to recognize and self-report stressful events. Therefore, it's vitally important for some member of the medical team to be asking every family about potentially traumatic events. As was mentioned earlier, many providers screen for potentially traumatic events by asking open-ended questions to determine if the child has been exposed to any stressful event. So these questions may include things like, has your home life changed in any significant way? Has anything bad, sad, or scary happened to you or your child? Are there any new behavior problems? Are there any new stressors in the family? Any questions along those lines to really get at if something stressful has occurred since the last time you saw that child. We also want to remember that as children get older and enter adolescence, it's especially important to ask these questions to both the parent and the child individually to be sure that the child has a safe space to disclose things that they may be uncomfortable talking about in front of their parents. An alternative to asking open-ended questions is to actually have children and caregivers complete a screening measure to assess for the occurrence of stressful events. So I have listed just a few here, and we're going to talk a little bit more about each one of these. But there are a lot of screening measures out there. I highly recommend looking at the National Child Traumatic Stress Network as well as the American Academy of Pediatrics. Both have wonderful resources with additional suggestions for screening measures. The benefit of some of these questionnaires and these screening measures is that not only do they assess for a potentially traumatic event, they also are going to allow primary care providers to quickly get at the severity of the PTSD symptoms, as well as how those symptoms are impairing the child's day-to-day functioning. So the first measure that I want to touch on is the Child and Adolescent Trauma Screen, or the CATS. This is a freely accessible questionnaire that screens for all three of those categories that I just mentioned. So exposure to potentially traumatic events, severity of PTSD symptoms, as well as functional impairment. The items map directly onto each of the criteria for PTSD, so allows a really nice diagnostic picture of what that child is experiencing. The measure takes about 5 to 10 minutes to complete. As you see listed here, there's a 15-item checklist to assess for potentially traumatic events, and the child or the caregiver just checks yes or no if that thing has happened. There is also a 20-item rating scale to assess for PTSD symptoms, and a 5-item checklist to assess for functional impairment. There are also multiple forms for this, which makes it kind of nice and easy. So there's a caregiver report for children ages 3 to 6, as well as children ages 7 to 17. And then there's a youth report or a self-report for children ages 7 to 17. This measure is available in both English and Spanish, and I've included both of those versions in the resource packet that we can send out. Scoring for the CATS is relatively quick and easy. As you can see listed here, this is the checklist that looks at symptom severity, and then the 5 questions at the bottom look at functional impairment. The total score is simply obtained by adding up this total score from for items 1 through 20. And then you can see it very nicely breaks it down into 3 levels, ranging from not clinically elevated to a moderate elevation to a severe elevation. So it really allows you as the provider to get an idea of how significant those PTSD symptoms are. The functional impairment items are not specifically scored, but there's 5 of them. It's pretty easy to get a quick and dirty overview of what areas of the child's life are being impacted. This measure was created by Edna Foa, which she continues to be a pretty major name in trauma research. Again, this measure is freely accessible, and it's a self-report measure for children ages 8 to 18. It can be administered as an interview or as a caregiver completed form, but the standardized version or the way it was created was a self-report form. Rather than a checklist of potentially traumatic events like the CATS offers, the CPSS-5 simply asks an open-ended question, kind of saying with a brief description of what a traumatic event is, and then an open-ended question asking the child to report if anything like that has happened to them. From there, there's 20 items to assess for PTSD symptom severity and 7 items to assess for functional impairment. Similarly to the CATS, it takes about 5 to 10 minutes to complete, and it's available in a variety of languages. Here you'll see that functional impairment items are, again, just a yes or no. They're not included in the total scoring, but again, gives you a pretty good overview of what areas of the child's life have been impacted. Scoring, again, you're just going to sum the scores of the PTSD symptoms, and you will get a range that's below clinical threshold or above clinical threshold. The cutoff score of 31 or higher is recommended for further clarification and treatment of probable PTSD. The last measure that I am going to mention is the UCLA Brief Screen for Child and Adolescent Trauma and PTSD. So there are a lot of versions of the UCLA screeners. Some of them cost money per administration. This specific screener is free, but you do have to request permission to use it. I've included the website here. It's, again, you just have to go in and kind of put your name in and request permission to use it. This is one of the most widely used instruments for assessing symptoms related to trauma in children and adolescents. And it, again, parallels DSM-5 diagnostic criteria for PTSD. The UCLA is a self-report measure for children ages 7 to 18. Very similarly to the CPSS-5, it is an open-ended question to assess for trauma history, both recent trauma as well as past trauma, an 11-item checklist to assess for symptom severity, and then a 1-item rating of frequency of symptoms. So this measure does not offer us a measure of functional impairment, unlike the other 2. What you do get from this measure that you don't necessarily get from the others is a total score as well as 4 subdomain scores, specifically looking at intrusions, avoidance, negative alterations in mood and cognitions, and hyperarousal. Similarly to the other scales, scoring is very straightforward and easy and really gives you levels ranging from minimal PTSD symptoms, mild PTSD symptoms, and anything 21 or above is considered potential PTSD. Before moving on, I also wanted to briefly mention the Adverse Childhood Experiences Survey. And it's a widely used survey to really determine types of potentially traumatic stress events. What I want to point out that while this can be useful kind of in population studies and in determining what a specific child has experienced, it doesn't give us information about the specific severity of PTSD symptoms, nor does it give us information about functional impairment. So when you are using and selecting measures that may work in your practice, keep in mind all those different areas that you may want to assess. So anytime that we are assessing for trauma, it's important for us to kind of follow up on and keep in mind a couple of really important areas. So first, we always have to keep in mind mandated reporting. There may be many times where this is the first disclosure of a potentially traumatic event. And so we want to keep in mind our responsibility to report as required. We also want to be appropriately screening for responding to suicide risk. And then beyond that, we want to be thoughtfully stratifying our treatment approach. So mandated reporting, I'm not going to belabor this since I'm sure that we are all fairly aware of our responsibility to report potential abuse and trauma. So our state laws require that we just need reasonable suspicion that abuse is occurring. And so keep in mind that it is not our job to investigate. It is not our job to determine if abuse or neglect is actually occurring. It is just our job to report it to the appropriate authorities. How to report, it's pretty simple. You can use the 1-800 toll-free hotline, or if there is no imminent risk of danger, you can report online at txabusehotline.org. And just keep in mind that there is a time limit to reporting, so be sure that you are doing that promptly after a child's appointment. In regards to responding to suicide risk, I'm not going to go in depth here. I highly recommend, if you have more questions on this topic, referring back to Dr. Kerr, Dr. Blood, and Dr. Johnson's presentation on screening for suicidality in pediatric primary care. But I did want to mention a few helpful resources just for determining risk of harm that I shamelessly pulled from their presentation. So these resources that I listed here are pulled from the National Institute of Mental Health's Ask Suicide Screening Questions Toolkit. So as you can see, there's very simple questions that can be asked or filled out by the patient. And this toolkit also provides a very nice flow sheet and roadmap of how to respond to suicidal ideation in an outpatient setting. So the responses range from, referring to mental health care for non-imminent risk of harm, creating a safety plan, all the way to admitting for inpatient psychiatric treatment. I think the biggest thing to keep in mind here is just be prepared to follow the crisis protocols at your clinic. Every clinic does this a little bit differently, so definitely be aware of how your clinic prefers to handle things and what that flow typically looks like. The other thing I wanted to include is just a sample safety plan that can be used with children and adolescents. This is the one that I typically use when I'm creating a safety plan with families. But it's just a good way to really identify warning signs of a crisis, people that they can call for help, emergency numbers, distractions, coping skills, as well as strength-based and future-oriented goals. And these are additional resources, again, that I have shamelessly pulled from Dr. Kerr and Dr. Blood and Dr. Johnson's presentation. So once we have, screened for our potentially traumatic events, dealt with mandated reporting and suicidality as needed, the next step that we want to look at is appropriately stratifying our treatment approach. So recall that not every child who is exposed to a traumatic event goes on to develop PTSD, which means that not every child exposed to a traumatic event will require a full course of trauma treatment. So what we want to be looking at when we are determining appropriate referrals, we want to be looking at symptom severity. We want to be looking at functional impairment, and the combination of those two things. So for example, you may have a child who doesn't have specifically severe symptoms, but their functional impairment has been incredibly impacted. And that's probably a child that we would actually want to refer to evidence-based trauma treatment. Conversely, you may have a child who has experienced something that you deem traumatic, but given their environment, given their support system, has pretty mild symptoms, is having no functional impairment, and that may be a child that you can provide some strength-based guidance and continued monitoring to. So this is just an easy way to kind of help keep in mind how to appropriately stratify that treatment approach. And then Elizabeth, I'm going to turn it over to you to talk briefly about examples of evidence-based care.
So this is not an exhaustive list. This is just interventions listed that are evidence-based, and the CPAN staff are available to assist you in locating them. So I'm just going to briefly go through each of them. So TFCBT, which is trauma-focused cognitive behavior therapy, is an evidence-based treatment approach shown to help children, adolescents, and their parents or caregivers overcome trauma-related difficulties. This can include child maltreatment. TFCBT helps children address distorted and upsetting beliefs and learn skills to help them cope with ordinary life stressors. It also helps the parents who are not abusers to effectively cope with their own emotional distress and develop skills that support their children. EMDR is a therapy that doesn't take a lot of talking in detail about the distressing issue or completing homework between sessions. EMDR focuses on modifying the emotions, thoughts, and behaviors resulting in the distressing issue. It allows the brain to resume its natural healing process. EMDR therapy is also designed to resolve unprocessed traumatic memories from the brain, and for many clients, EMDR therapy can be completed in fewer sessions than psychotherapy, other psychotherapies. CBT, which is thought challenging. CBT is a psychosocial intervention that aims in improving mental health. CBT focuses on challenging and changing cognitive disorders and modifying, improving emotional regulation, developing personal coping strategies that help solve current problems. DBT is a type of cognitive behavior therapy, and it's used to identify and change negative thinking patterns and push positive behavior changes. DBT is also can be used to treat suicide and other self-destructive behaviors, such as self-harm. And then play therapy is a form of therapy used primarily for younger children. Children may not be able to process their own emotions or articulate problems to parents and other adults. While it may look like ordinary playtime, play therapy is much more than that. A trained therapist can use playtime to observe and gain insights into the child's problems. The therapist can also help the child explore emotions and deal with unresolved trauma. Through play, children can learn new coping mechanisms and help redirect inappropriate behavior. And then I think it's you, Dr. Simmons.
Perfect. And like Elizabeth mentioned, this is not an exhaustive list, but these are really the examples of evidence-based care that have the most research backing to really support being an effective form of treatment specific to trauma. So as we kind of continue on our roadmap, after we think about stratifying our treatment approach and referring either to specific trauma-informed care, to mental health care, or to providing continued monitoring, Another really useful thing that primary care providers and their medical staff can do is provide brief in-office interventions specifically targeted towards some of the things that traumatic stress can affect. So for example, with sleep problems, sleep education can be a great way just to provide information on the amount of sleep that's needed and ways to increase sleep hygiene. For example, being sure that the bedroom is a secure and safe place, the child has a plan to cope with nightmares, and caffeine and other substances are limited. Relaxation skills can also be extremely helpful to decrease sleep problems, as well as to help cope with hypervigilant and intrusive symptoms. So simple techniques exist for children and adolescents to calm their physiological arousal. These may include things like deep breathing, progressive muscle relaxation, visualization, grounding, etc. Many of these techniques have been adapted for younger children as well as lower developmental levels. For example, children can learn cookie breaths, so breathing in deeply through the nose to smell the cookies and blowing out through their mouth to cool them down. Younger children can also learn simple muscle relaxation via mimicking a toy soldier and a rag doll, and then comparing how their body feels differently between those two things. For depressed and highly anxious children, helping parents formulate a way to return to their normal routine and return to their normal activities is hugely important. We want children to be active and involved in the things that they enjoy as quickly as possible. For anxious kids, we also really want to help parents understand the role that avoidance can play in maintaining symptoms and really helping, again, the child get back to their normal routine as quickly as possible. So this may include simple things like addressing school avoidance, as well as helping parents to not reinforce avoidance symptoms with their child. Another really simple intervention is just helping parents and children recognize triggers and communicate about their needs, and that can help reduce symptoms. Included in the resource packet that we have put together, we included a quick handout on sleep hygiene for children, as well as several handouts about simple relaxation skills for children and adolescents. Providers play a vital role in monitoring symptoms and possible progression of symptoms. So we want to be doing regular follow-up at normal intervals. If the child's symptoms are improving and they are getting back to their normal routine, it seems that whatever intervention you have chosen is likely effective. However, if symptoms are increasing or are failing to decrease, another approach or a higher treatment level may be warranted. Additionally, we want to keep an eye on just normal traumatic responses over time. So it's normal for every child who experiences a traumatic event to experience some traumatic stress symptoms immediately following the event. However, the vast majority recover without any specific intervention and usually recover within kind of that month period. So continually following up and doing ongoing screening is vitally important in identifying those children who may go on to develop more PTSD symptoms and may require additional intervention. Finally, I just wanted to quickly mention the possible role of medication. So there is no medication specific to PTSD, but psychiatric medication can play a role in improving specific symptoms. So things like sleep disorders, pre-existing anxiety, pre-existing depression, as well as managing coexisting ADHD. So since I am not a psychiatrist, I highly recommend consulting our wonderful child psychiatrist through the CPAN network if you have additional questions or concerns specifically related to medication and medication management of PTSD symptoms. Okay, so that was a very quick and dirty overview of, assessing for, screening for, and responding to trauma in the primary care setting. So Laura, I can turn it over to you to talk a little bit about CPAN and to open it up for questions.
Absolutely. Thank you so much, Dr. Simmons. So what I'd like to do is provide you each an opportunity to ask questions. I'm going to put myself on video here a little bit. Provide you an opportunity to ask questions of our presenters. They did a great job in sharing information about the screening for childhood abuse and trauma in primary care. And I suspect you have some questions, even though this is not a new topic for most people. So I would like to open that up. Please place your questions in the chat, and we will review them here in just a moment. What I would like to do is I'm going to switch screens here for just a moment and just share a little bit about the Child Psychiatry Access Network. One moment. It's like I'm juggling a few things here at one time. All righty. So the Child Psychiatry Access Network was brought through the Texas legislature in the 86th regular legislative session 2 years ago. And the legislature was concerned about childhood abuse, not abuse, anxiety, depression, increasing suicide rates, and obviously we've been also seeing school shootings. So the children's mental health was really on their minds during that time. And so what they did is they passed, they worked through Senate Bills 10 and 11 and then passed funding for what was called the Texas Child Mental Health Care Consortium. And that consortium is made up of 12 network hubs that are located in 12 regions across the state. These hubs provide telemedicine-based psychiatric consultation by child psychiatrists, care coordination for non-medication related care, and referrals and resources, and continuing education to PCPs among the PCPs that serve children and adolescents throughout the state. Boy, my mouth is just not working this afternoon. So CPAN has specifically assigned child psychiatrists that work 8 to 5 Monday through Friday that can serve as a consultation for PCPs, really to bring together that biopsychosocial approach that children and adolescents need for mental health care. These services are at no cost. They are funded by the state of Texas, and so there's no fee at all for the PCP, the clinic, the patient, or the health plan. One of the other availabilities, and you'll see on the screen, is that we do provide, obviously, the CMEs. Our team here in Tyler attempts to do so twice a month, though May being Mental Health Awareness Month, we have provided one each week. Beginning in June, it will be the first and third Wednesday of the month. So this is our team. Just a quick visual. We have, as I mentioned, 3 child psychiatrists that work on our team. We have Elizabeth, who you've met today, and her colleague Wiley. They are behavioral health specialists, and myself as the program manager. So our strategy really is a 3-pronged approach. That real-time psychiatric telephone consultation with one of our psychiatrists if there's a need for that. If you'd like to discuss medication management, complex cases, or just review overall what needs might be best for that care plan. With that, we also have non-medication related support and services, not only through our psychiatrists, but also through our therapists, Elizabeth and Wiley. And finally, the care coordination services, which can assist with referrals and resources. I think about the service of CPAN as being kind of like having a child psychiatrist and a referral coordinator in your pocket that you can pull out at any time. It's as simple as a phone call to our team, toll-free number, and then you get either Elizabeth or Wiley on the phone for this region. If you are in a different region of Texas, you can call our same phone number. I'll share that with you shortly, and then choose the region they're associated with. One thing that I want to mention, which I think is really important, is there are no limit to the calls that you can make to CPAN. If you have a patient you've been working with and what you've been doing, what you've tried hasn't worked, we can consult with you. And then you can actually work alongside, or that psychiatrist can work alongside you in continuing consultation if one treatment plan didn't work and you want to make a change to that treatment plan. Not a problem. You can call as many times as you want. There is no limitation on that. And then finally, using our services. It's as simple as that toll-free number, 888-901-2726. Or if you want more information, you could certainly email us at cpaninfo@uthct.edu. When you call, Elizabeth or Wiley will answer the phone. We'll ask you a couple of questions, not a whole lot, just a couple of questions about the patient. And then you can either ask for a call back by one of our psychiatrists if that's what your need is, or we can schedule a time for one of our psychiatrists to call you back. Again, Monday through Friday, 8 to 5, excluding institutional holidays, and our next one will be Memorial Day. Simple. We try to make it very quick. Typical length of phone calls is about 5 minutes with our child psychiatrists. We know that you don't have a whole lot of extra time, and so what I would like to do is provide an opportunity for Dr. Simmons or for Elizabeth to just share any other examples. We have a couple of minutes left, maybe some examples that might be more relevant for our PCPs that they might be seeing that would be excellent referrals for screening for abuse and trauma and follow up with that. So I'm going to hand that over to you. Dr. Simmons?
Sure. So, I mean, personally, this just because this is my area of interest, but I think also in line with trauma-informed care, any patient that walks into a primary care setting is a good candidate for screening. So given that we know how frequently traumatic events occur, and just how widespread those are, I think that it's incredibly important to be universally screening for potential exposure to traumatic events. And then I think really, carefully thinking about from that, if really looking at the specific PTSD symptoms that a child is presenting with, and then like we mentioned, stratifying your treatment approach from there. Elizabeth, I'm not sure if you have anything to add to that.
No, I do not.
Because like I said, really the response to any traumatic event can vary incredibly widely. So you may have a child who was involved in a car accident. Actually, Elizabeth has a really good example of this, I believe you said it was twins who were involved in the same car accident.
Yes. So I had, and this was, so I was their therapist. I saw them after the fact, but it was a little boy and a little girl. They were both, I think they were 10 at the time. They were in a severe car accident. No one died, but the little girl was hurt, broken leg, and she fractured. She had some broken bones. And so she was on the side of the car that was hit. The brother was not. The sister had some anxiety and had a little bit of hypervigilance, but not too bad. The brother would have night terrors. He regressed. He had a lot of the symptoms of PTSD, and he wasn't on the side that got hit, but he witnessed it. So again, these were twins, same car accident, different placement, but and very, very different reactions to the trauma, and I thought that case was fascinating.
Yeah,
and I used EMDR with both of them. That's kind of my go-to therapy is EMDR, and they both were fine, and we were able to finish up therapy, and she healed very, very well, and I actually get Christmas cards from them every Christmas, so that's really nice.
So I think that's just a great example of how drastically trauma responses can differ, even between two individuals who are genetically very similar and who experienced the same event. Our approach to treating those two things may look different, which is why we highly recommend actually looking at symptom severity, functional impairment, and then making decisions about additional referrals from there. As I mentioned, all of these resources we put together in a resource packet that includes a copy of the PowerPoint for today, as well as a full-size version of that roadmap of care we discussed, copies of the screening measures that we discussed, as well as simple relaxation and sleep hygiene that you can offer patients. So please don't hesitate to reach out via the CPN email, and we would be more than happy to send you a copy of those resources. Okay. I guess if no one has any additional questions, we can go ahead and wrap up and everybody a few extra minutes to fill out the survey and do CME credits.
Thank you very much, Dr. Simmons and Elizabeth. We really appreciate your time today. I have put up the QR code for folks to use to complete their evaluation. The link has also been put in the chat. Again, thank you very much for your time. We look forward to having all of you join us again next week for a new presentation on PMDD, and have a great day.